Diagnostic Approach to Anemia for Medical Students. Hello, whether you're in the clinic, on the wards, or preparing for exams, understanding how to systematically evaluate anemia is essential. So, let's break it down, step by step. Step 1. Confirm the diagnosis. Anemia is defined as a hemoglobin or hematocrit level below the normal range for age and sex. But don't stop at the number. Ask, is this a true anemia? Could it be dilutional, like in pregnancy or fluid overload? Always correlate with the clinical picture. Next, assess severity. Mild, moderate, or severe. This helps determine urgency. Severe anemia, say, HB less than 7 grams per deciliter, may require immediate intervention. Step 2. Classify by red cell size, the MCV approach. The mean corpuscular volume, or MCV, is your first clue. It divides anemias into 3 broad categories: microcytic, MCV less than 80 fluid, normocytic, 80 to 100 fluid, and macrocytic, MCV greater than 100 fluid. This simple step guides your differential diagnosis. Let's start with microcytic anemia. The big 3 are iron deficiency, thalassemia, and anemia of chronic disease. To differentiate, check iron studies. Low serum iron, low ferritin, high TIBC, and high transferrin saturation. That's iron deficiency, anemia's most common cause worldwide. But if ferritin is normal or high, think anemia of chronic disease. And if iron studies are normal but you suspect thalassemia, look for elevated RBC count and consider hemoglobin electrophoresis. Now, normocytic anemia. This is trickier. It could be early iron deficiency, acute blood loss, hemolysis, or anemia of chronic disease. Here, your next step is the reticulocyte count, a window into bone marrow response. A high reticulocyte count suggests the marrow is responding, likely due to blood loss or hemolysis. A low count means the marrow isn't keeping up, pointing to decreased production, like in renal failure, bone marrow disorders, or nutritional deficiencies. Don't forget the peripheral smear. Schistocytes. Think microangiopathic hemolysis. Spherocytes. Possibly hereditary spherocytosis or autoimmune hemolytic anemia. Finally, macrocytic anemia. 2 main types, megaloblastic and non-megaloblastic. Megaloblastic anemias are due to impaired DNA synthesis, usually from vitamin B12 or folate deficiency. Look for hypersegmented neutrophils on smear. Non-megaloblastic causes include alcohol, liver disease, hypothyroidism, or certain medications. So, check B12 and folate levels. If B12 is low, assess for pernicious anemia with intrinsic factor antibodies. To recap: 1. Confirm anemia and assess severity. 2. Classify by MCV. 3. Use iron studies for microcytic. 4. Use reticulocyte count and smear for normocytic. 5. Check B12 and folate for macrocytic. Always consider the full clinical picture, history, physical exam, and comorbidities. A patient with fatigue, pallor, and koilonychia. Think iron deficiency. A vegetarian with neurological symptoms. Suspect B12 deficiency. Diagnosing anemia isn't about memorizing lists, it's about thinking like a detective. Use lab values as clues, connect them to your patient's story, and follow a logical pathway. Master this approach, and you'll not only ace your exams, you'll provide better, faster care for your patients.